This presentation is designed to give an overview of crisis services as they develop in Virginia, with special emphasis on plans in Region 5. To best understand our crisis continuum, we need to take a little bit closer look at how we got here. This graphic provides us a nice overview of the development of community-based crisis services. It includes the development of the first 24-hour crisis hotline in 1958 and moves through key steps including crisis intervention team training, the establishment of a national suicide prevention lifeline, the development of the concept of air traffic control to monitor statewide crisis systems, national best practices including Crisis Now and the transformation of crisis services in the community, and a number of the concepts that we'll talk about as we go through this slideshow, including the 988 Suicide Prevention Lifeline. The 988 Crisis Call Center serves as the key entry point into the crisis services system according to the national best practice models. Let's talk a little bit more about the Regional Crisis Call Center. These are 24/7 clinically staffed hubs and crisis call centers that provide crisis intervention capabilities through phone, text, and chat, and they meet all National Suicide Prevention Lifeline standards and are accredited with the American Academy of Suicidology. They complete risk assessment and engage individuals that are at imminent risk of suicide and offer air traffic control capabilities, including dispatch of mobile crisis clinicians that we'll talk about in a few moments. Western Tidewater Community Services Board operates the central hub for crisis and the call center, serving as the primary entry point into the crisis system in Region 5. Call center staffing will be subcontracted with a National Suicide Prevention Lifeline partner that is already accredited to answer and triage all phone calls. Western Tidewater Community Services Board will maintain responsibility for all call follow-up and care navigation at the point of call. This includes linkage to behavioral health providers and community services boards in the individual's locality to ensure that everyone is properly linked to the services that they need to ensure ongoing stability in the community. The call center also accepts transfer and handoff from 911 centers to appropriately dispatch behavioral health services when appropriate. There's an initial level of care assessment completed at the call center that helps to identify the appropriate response that will be taken following the initiation of the call. To best understand our crisis system, we also must understand Virginia's Marcus Alert, some legislation that was designed in honor of Marcus David Peters, a high school biology teacher who was killed by a police officer in Richmond while experiencing a behavioral health crisis in 2018. Marcus Alert legislation allowed us to identify specific levels of behavioral health crisis. The first level being a behavioral health need that can be resolved at the point of a crisis call with the crisis call center through some immediate crisis intervention via telephone. Level 2 involves behavioral health crises that require immediate dispatch of a mobile crisis clinician or clinicians to intervene in the situation and provide crisis intervention face-to-face with the individual making the call. There's no immediate threat to physical harm or indication of homicidal intent during these calls, meaning that a behavioral health clinician can be dispatched without any backup from law enforcement officers. Level 3 calls are those behavioral health crises that require an immediate dispatch, but due to presence of firearms and immediate risk to health and safety and or a homicidal intent or active psychosis that indicate a threat level of aggression, a law enforcement officer may be co-dispatched with a mobile crisis clinician to intervene. During this time, the law enforcement officer and behavioral health provider take a treatment first perspective and intervene without or with the least restrictive alternatives. A level 4 call are those behavioral health crises that involve an immediate threat to the health and safety of the individual, such that EMS or law enforcement respond immediately and behavioral health interventions are not provided until the scene and safety of the individual and individuals in the area are secured. A little more about call center care navigation. Regional Crisis Call Center navigators are trained behavioral health staff that provide follow-up for all callers at the Regional Call Center and will ensure the local CSB is aware of the event and potential need for services. The primary responsibilities include appointment reminders, assistance with seeking local CSB same-day access care, and to ensure that the crisis has been resolved through contact with the regional call center. Care navigators will encourage participation in follow-up crisis stabilization services when appropriate, and care navigators will also serve as a key source of assessment of the call center performance and outcomes. The Crisis Call Center serves as the heart of the community-based crisis continuum. They're essential to linking to ongoing services and supports, as we'll see over the next couple of slides. The 988 Regional Crisis Call Center serves as a parallel to the 911 public safety answering points that we see today. The 988 call center will accept calls from our existing regional crisis lines as well as from the National Suicide Prevention Lifeline. Their focus is to provide triage assessment and a disposition linkage to existing crisis services. The 988 call center and 911 will have a warm handoff protocol that will allow callers to have no wrong door to enter the system and ensure that they receive a treatment-first perspective regardless of their level of need. The 911 public safety answering points will continue to dispatch law enforcement and EMS to Marcus Level 3 and 4 calls, and linkage can then be provided to ongoing services through the 988 Regional Crisis Call Center. All of these services will feed into our comprehensive crisis continuum that will move from left to right for increasing levels of care. Starting with the call center itself, providing support and linkage to individuals at the time of the call, 24/7 mobile crisis teams that will respond to an individual in the community or their home depending on their level of need, a developing service in 23-hour crisis receiving centers that provide observation and direct linkage to psychiatric, peer support, and other services to intervene at the time of a crisis when an individual can't be stabilized in their home. And best practices indicate that we should co-locate those centers with residential crisis stabilization units to ensure that individuals that are not able to achieve stability in the 23-hour period have direct access to residential crisis care outside of a hospital setting. And the final step in our continuum is pre-admission screening for individuals under an emergency custody order to determine if they meet criteria for temporary detention for the protection of their health and safety. Mobile crisis teams provide a key level of support across the crisis continuum. They serve as a connecting point between the crisis call center and direct intervention in the home or community. The mobile crisis teams in Region 5 are comprised of specific specialty teams that serve individuals with mental health, intellectual and developmental disabilities, service member veterans and their families, and/or geriatric and dementia patients. They provide a direct link to the Outpatient Community Services Board services and/or a center-based care. Western Tidewater Community Services Board currently serves as that central hub for all of the mobile crisis response, and they also dispatch teams from co-located response sites that are located in Virginia Beach as well as the Middle Peninsula and Northern Neck Community Services Board. Crisis receiving centers and 23-hour crisis observation sites build on Virginia's history of crisis intervention team assessment centers to provide short-term, non-hospital, center-based levels of care for individuals that cannot be stabilized in their home or community. They're ideally staffed with CIT officers to allow for transfer of custody for individuals that may be under an ECO, and they have a number of services to include clinical and nursing assessment, psychiatry, counseling, peer support, and psychoeducational supports. They operate from a no-rejection philosophy to accept voluntary walk-ins, mobile crisis referrals, and police drop-offs. And their best practices recommend that residential crisis stabilization units are co-located on campus to minimize barriers between transitions of level of care.